everybody. This is the first lecture that we're going to talk about. It's disorders of the eyes and the eyelids. Basically, you can find the information about most of these issues or situations from the current book. And certainly the information in the current book will help supplement some of the missing pieces in some of these lectures. So typically, when we do these lectures, we talk about more about the conditions surrounding the eye. We don't talk about the anatomy and the physiology, and nor do we spend time on some of the diagnostic tools or assessment pieces, because that's everything that you covered in 619. So to be more efficient, we talk more about kinds of signs and symptoms and how to manage those conditions than actually your assessment skill set that you've already been able to master. So just for graphic reasons, this is the picture of the eye and typically the parts of the eye that we want to make sure that we can take into consideration when we see somebody with an eye disorder. The first most common issues are the stye and the chalazion. These are conditions of the eyelids. The stye is typically a result of a staph infection or staph abscess, and it presents with a red, swollen, tender upper or lower lid. Typically, the treatment is warm compresses and a bacitracin or erythromycin ophthalmic ointment to the lid, usually 3 times a day. The typical thing about the stye is that it's right on the lid. It's right on the edge of the eyelid itself, whereas a chalazion is actually into the actual lid itself. And I'm going to show you a picture in a second. We find a lot of times that people get styes, especially in the warm, hot weather, because when people are sweating, they rub their eyes and they have staph on their hands, and then they tend to get staph onto their eyelid itself. Or during allergy season, when people are rubbing their eyes because they're watering or tearing, are usually the reasons why that happens. A chalazion, on the other hand, is an inflammation of the meibomian gland. It's a hard, non-tender swelling of the upper or lower lid. Sometimes it can have some redness and swelling to the conjunctiva. And typically the treatment, typically by current, will suggest that it's an incision and drainage. However, I've seen a lot of ophthalmologists try and treat this with warm compresses and some antibiotics to try and get the inflammation down. If the inflammation doesn't go down, then they would have to do an incision and drainage, and that would be a trip to the ophthalmologist. But most often we can try and get these with warm packs and some sort of penicillin antibiotic like a dicloxacillin, things like that. As you can see here, on the upper left hand, the patient has a stye because it's more up towards the lid, and you can see very easily that the lid itself, right along this side, has got a little bit of an inflammation. Whereas this patient on the lower right hand side has got a chalazion where there's an actual non-inflammatory but red lump right in the eyelid itself. Blepharitis is another condition of the eyelids, and it's a common inflammatory condition that is usually from staph or it's seborrheic in nature. And usually when patients have blepharitis, they usually will have some sort of seborrhea of the scalp, the brows, and the ears. Seborrhea is more like a flaky type of inflammation or rash. Typically the treatment is with a warm cloth and baby shampoo or kind of these non-drying, milder shampoos. This is a picture of somebody who's got blepharitis, and this person's got certainly some ointment over the top of their lid, but typically it's a flaky inflammation of the lid, which I'm sure that you have seen before, especially in the older patient. And an entropion or an ectropion is an inward turning of the lower lid. It occurs in adults because of the degeneration of the lid fascia. Typically, patients require surgery for this, and the entropion is the inward turning and the ectropion is the outward turning. If somebody has a problem with their lid, then you need to send them to the ophthalmologist where they will have surgical repair. Conjunctivitis is moving more towards the disorders of the eye itself. It is the most common of eye diseases, and most often it's due to viral or bacterial reasons. A mode of transmission for a bacterial cause is mostly from the fingers, the towels, and handkerchiefs. Right down here in the lower corner of the slide is usually the more common signs and symptoms, and the presentation is most often from an adenovirus. Some people will say that they've got pharyngitis, fever, malaise, and they have a lot of watery discharge. Contaminated conjunctivitis can also come from contaminated swimming pools, and the treatment is really, if it's a viral reason, there's really not much to do for it. But sometimes when people get these kinds of viral conjunctivitises, it turns into a bacterial conjunctivitis because they're rubbing their eyelids. So cool compresses might help, and a sulfonamide might also help to prevent any kind of secondary infection. Here's a person who has classic pink eye. They have a very injected sclera and conjunctiva. It's very watery and loose, and the eyelashes themselves look like they've got matted material or discharge around them. They usually might have some material in the inner canthus as well. For bacterial conjunctivitis, the most common bacteria is staph, but strep, Haemophilus, and Pseudomonas can also be culprit. They have copious purulent discharge. So, like in viral conjunctivitis, where it's just a watery discharge, in the bacterial conjunctivitis, there is copious amounts of purulent stuff. They might complain of mild discomfort, and typically the treatment first line is a sulfonamide, like a Blefton or sulfacetamide, and it's usually 1 to 2 drops every 3 to 4 hours while awake for 5 days. I've gone to lectures about conjunctivitis, and most recently was in California for a lecture by an ophthalmologist who had practiced for about 30 years. And he said out of everything, out of all of the newer fluoroquinolones and out of all of the eye drops that have come out on the market, it's still Blefton, which is the oldest medication and the cheapest medication that seems to work the best. The only contraindication for this medication, however, is somebody who has an allergy to sulfa. Fluoroquinolones are easier to take sometimes because you don't have to use them as often, but typically they are expensive, and they certainly don't work as well as the Blefton. For an allergic conjunctivitis, it looks a lot like the viral conjunctivitis. It's a lot of itching and tearing that come from the eyes, and the treatment is typically topical histamine like Patanol or Claritin and Zyrtec. A lot of times you won't use topical histamine because those Patanol medications tend to be expensive and are not always covered by the insurance companies. When somebody has conjunctivitis, the most important teaching point is to make sure they wash their hands and avoid contact of their hands to their face and their eyes. If they are wearing contact lenses, they need to make sure that they get them out of their eyes, that they discard any of the disposables, and that they wash their contact lens. They also need to discard all of their eye makeup because they can recontaminate themselves. Change their washcloths and their pillowcases after they've been on after they have started the medication. And the one thing to make sure that you tell them with regards to contact lenses is that they do not put contact lenses back in until the infection is completely cleared. If a patient has conjunctivitis and wears their contact lenses, the bacteria grows underneath the contact lens and can cause wearing and erosion of the cornea, in which case they could have require extensive eye damage or vision damage. So it's really important to make sure that you tell them that the contact lenses come out. A herpes zoster ophthalmicus is a shingles that actually involves the trigeminal nerve that branches into the ophthalmic division. People will complain of malaise, fever, headache, and periorbital burning and itching that precede the eruption, usually 2 to 3 days. The treatment is high-dose acyclovir or Valtrex. Acyclovir is 800 milligrams 5 times a day. Valtrex is 1 gram 3 times a day. And Famvir is 250 to 500 milligrams 3 times a day. It needs to be started within 72 hours of the rash developing, but I will tell you, the most important take-home message is that anybody that's got herpes zoster, and you think might have ocular symptoms, they need an immediate ophthalmology referral. You can start them on the antiviral medication, but it's very important that you get them to an ophthalmologist. Shingles that goes into the eye and that invades the eye is going to cause blindness. So it's very important not to wait. Here's a patient who has shingles. It started on his forehead and started to travel down. When it got down to his nose and started to move over onto the upper eye, he went right to the ophthalmologist. And even though his eye looks very red and injected, he was put on the Valtrex, and he was also put on a antiviral eye drop, and he wound up being able to save his vision. Glaucoma is a chronic disease that's common in elderly people, not elderly, anybody who's over the age of 50. There is an issue when somebody has acute glaucoma, which presents with somebody who has an onset of severe pain and halos around lights. They might have a red eye, a dilated pupil, and they have what's called a steamy cornea. If you were to look at their cornea, it might be kind of opaque as opposed to clear. If you were to touch the globe of their eye, you'd find that the eye was very hard to palpation, and these patients need immediate ER and ophthalmology referral. This opposed to chronic glaucoma, which is more of a chronic disease. Typically, patients will come in and they don't have any symptoms, but if it's left untreated, they have progressive bilateral loss of peripheral vision and an elevated intraocular pressure. Typically, patients are found to have chronic glaucoma on a routine eye exam when they have their eye pressure tested. This is why, from a preventative standpoint, we have everybody go to an eye doctor and have an actual screening eye exam. Uveitis is another eye condition. It's typically more of an eye concern or an eye emergency, ocular emergency. It's usually immunological, but it can be possibly infective. Acute anterior uveitis usually presents with pain and redness, some photophobia and visual loss, and it usually responds to corticosteroids. But again, these people need to see an ophthalmologist immediately. This is a patient who had a uveitis. You can tell that they have a little dilated pupil. Their sclera is injected, but the patient came in complaining of eye pain. Retinal detachment is a ocular emergency. Typically, patients complaining of problems with visual fields. So they'll say that it feels like there's a curtain closing over the top of their vision, or they have a sudden onset of visual loss in the eye. There's no pain or redness, but again, these people need referral because they need surgical intervention. Macular degeneration is a chronic condition. It's usually a deterioration of the central vision in one or both eyes. There is no pain or redness, and it's more commonly in elderly patients. There is some sort of genetic predisposition to this. Some patients will say that they have family members who had macular degeneration as well. Typically, they will complain of central vision loss, whereas glaucoma is peripheral on the outside. Macular degeneration is right dead center. Central and branch retinal vein occlusions are a sudden monocular loss of vision in one eye. They have no pain or redness, and usually patients who have hypertension, hyperlipidemia, or diabetes are more prone to these types of conditions. And typically it's a sudden loss of vision. They'll say that they have no visual field and no sight coming from their eye. And these patients, again, go right to the ophthalmologist and usually get referred to retinal specialists. We have had a number of patients who have had a history of diabetes and come in and say that they can't see anything out of their eye and have certainly had, luckily, their vision restored, but it's with ophthalmology intervention. Central and branch retinal artery occlusions are very similar to the retinal vein occlusions. They have a sudden monocular loss of vision. Now, when we talk about monocular loss of vision, it means that they can see, they have vision in the loss of one eye, not both. So if you ask them to cover the affected eye, they're able to see very efficiently. They do not have any pain or redness, but in patients with retinal artery occlusions, we want to look for carotid and cardiac sources. So listen for bruits, listen for any kind of murmur or atrial fibrillation. And we also want to look for giant cell arteritis. Giant cell arteritis is a condition that affects the visual fields in the temporal region, and it's usually diagnosed with a SED rate of elevation. And typically, these patients need to be treated with high doses of prednisone in order to try and restore vision. But if these people have, again, a sudden loss of vision, they need to see an ophthalmologist as soon as possible. There is a growing epidemic of diabetes, especially in the older population, and in all of cases, when patients are diabetic, they need to have routine eye exams every year. So when somebody comes into your office who's got diabetes, the first thing you're going to ask them is when was their last eye exam, and make sure that they have a dilated eye exam every year. Diabetic retinopathy is a loss of vision and a leading cause of blindness for patients in 20 to 65, especially when they're diagnosed with diabetes. It's present in about 40% of all diabetic patients. They need regular screening, and the best way to control retinopathy is to control their diabetes, make sure that they have good cholesterol numbers, and make sure that their blood pressure is controlled. That is the eye exam lecture. If you have any questions, please let me know. And at the same time, also make sure that you look at the chapters in the current book for additional eye disorders and treatment plans.